Thank you, sir. Okay, can we hear me all right in the back? Wonderful. Well, I'm very happy to be here, especially with this diverse panel. I'm going to speak from the federal angle, which isn't necessarily going to be as exciting as you may have alluded to, but I think it's really great that we have a diverse panel because really in terms of tobacco control, the great deal of momentum and innovation and spread of ideas has occurred at the local level, which in turn has expanded to the state level and ultimately reached the federal level. And in the end, the feds are normally the last to implement a lot of these policies, but the innovation is really occurring at the local level. And so today, in terms of the various interventions that I'm going to go over, I'm really going to keep coming back to the same statement, is that we really know what works in tobacco control. And tobacco control is one of those fields where we have the luxury of over 50 years of experience. And we've had decades of trying to figure out what works, and now we know what works, but we're in the predicament in that it's not necessarily spread to the populations who need it most. And although we've made progress over the past 5 decades since the first Surgeon General's report, we still have marked disparities in tobacco use, and innovative and emerging products like e-cigarettes are now infiltrating the market. So although we've made progress, it continues to diversify, and we're still faced with a lot of issues, despite the fact that we know what works to address it, and if we just implement that, we could make great inroads. And so in terms of the major interventions, there's been a slew of reports. The Surgeon General has put out 32 tobacco reports over the past 50 years on this issue, and there's other WHO and CDC's best practices, but it all comes down to really 4 major interventions in the context of comprehensive tobacco control programs. And so all 50 states currently have tobacco control programs, and CDC has what they call the standards for a comprehensive program. But the 4 major interventions as part of that are 100% smoke-free policies, which we've already heard somewhat about, tobacco price increases, cessation access, and hard-hitting media campaigns, which again we've heard a bit about. And so I'm going to delve into all 4 of these briefly in terms of addressing the spread and the scope and where we're currently at the federal level, and hopefully we'll delve into it further at the local and state level with the next few speakers. But first, I'd like to start off this slide to show how far we've come. And you can see that in terms of the tobacco epidemic, we really peaked in the 1960s. And I'm the first to say that the federal government had a great deal of involvement in what addicted the American populace to tobacco. They were put in the rations in World War II. And then they came home and then introduced their wives and other family members to the product as well. So there's a slight delay in the bell curve for women, but in men, it's generally that World War II cohort. And of course, the tobacco industry did not help the situation further. And so we've seen marked increases in the use up until about 1964, which was when the first Surgeon General's report was released on tobacco. And at that time was when we really started to implement these population-proven interventions that we know work. And it's no coincidence that we've seen marked declines over time as the knowledge of the dangers of tobacco use, as well as secondhand smoke among bystanders, has rapidly proliferated the population, and social norms have changed regarding the social acceptability of both tobacco use as well as using these products among bystanders. But as you can see, again, in 2013, we still have about 18% of the adult population that's using cigarettes, and the tobacco product landscape continues to diversify with new products. And the other factor is funding, and that's really the biggest inhibitor of implementing a lot of these interventions and ensuring that they spread. And so to put this into context, the state tobacco revenue from taxes and master settlement agreement payments is about $25 billion per annum, and the federal is about $15.6 billion. And the tobacco industry spends about $8.8 billion per year to advertise their products. And CDC has established some recommended levels of what states should spend, which is about $3.3 billion, so a small portion. But if you look at what states are actually spending on tobacco control, it's absolute minutiae. It's about $500 million per year. And so we know what works, but again, people aren't using the funds to implement the strategies that we know work to effectively reduce tobacco use. And although there's a large income from revenue, if we just implemented a small portion of that in tobacco control, we could make great inroads, particularly among disparate populations. And so again, coming back to these 4 population-based interventions, and I like to call this the vaccine for tobacco use. And people always tell me, wouldn't it be great if we had this vaccine, we could just inoculate the entire population and no one would be addicted to tobacco use? And that's actually in the works. There are people trying to make that happen, but I tell them again, we have the vaccine. We know what works. These are the 4 interventions. We just need to implement them, and we need to make sure that it's equitable implementation so that we address all of the groups and don't leave people behind. And again, those are smoke-free policies, price, cessation treatments, and counter-marketing. So I'll just start with comprehensive smoke-free laws. In these next few slides, I put two maps from 2000 to 2014 to kind of help demonstrate the spread of these policies over time and over a relatively short time period. If you think about public health interventions, over a decade making this type of progress is still commendable, even though we do have some disparities. So back in 2000, there were no states with comprehensive smoke-free policies. Delaware was the first in 2002, and we saw rapid proliferation. Currently, we have 26 states in the District of Columbia with a comprehensive smoke-free policy that prohibits smoking in all indoor areas of work sites, restaurants, and bars. But momentum has dragged considerably in recent years, and one of the largest factors that's inhibiting this is the issue of preemption, and that, as I noted before, a lot of the momentum for these policies is at the local level. But if you have a state law that preempts localities from taking action, you don't have that initiative to start the discourse at the local level, which in turn can spread across the state, ultimately leading to a statewide policy. And so there's ultimately other factors as well, but although we've had momentum, there's still been a stall, and we haven't had a statewide law implemented since 2012 at the national level. And it's no wonder that these work. This is just an example of serum cotinine levels, which is a biomarker of nicotine that we measure in the population. It's kind of a gold standard. And you can see that back in the late 90s when we start to see marked declines. And so that was when local level smoke-free policies started to proliferate in this country. And then the statewide laws started being implemented around 2001, 2002. And so you can see that in terms of evaluation, we can see that these policies are really working. But again, we've had a lag in policies in recent years, and we're not seeing the same type of progress. In 2012-13, it's down to about 25%. So we're still getting down there, but again, still a quarter of the population. The next is price. Tobacco product price. Increasing price is the single most effective method to reduce consumption. This is proven time again, regardless of locality, state, national, international. And this just shows over time that as you increase the price of tobacco products, in this case cigarettes, you're going to see declines in consumption. And we've made great inroads. But again, there's variation in the implementation of these interventions, and it has not necessarily spread equitably across states. So this is just an example of cigarette excise taxes. And you can see that there's marked variability. It ranges from about 17 cents a pack in Missouri up to $4.35 in New York. And it's no surprise that smoking prevalence is the lowest in the states with the highest cigarette excise taxes. And also, as we discussed before, there's that kind of tobacco belt in the South where we have the highest rates of smoking and other tobacco use, as well as other comorbidities, but also the lowest level of taxes, the lowest level of smoke-free policies, and these other interventions that we know work. Here's an example of cessation in terms of tobacco quit lines. Back in 2000, we had very few states that had quit lines, and now we have all 50 states in the District of Columbia that have quit lines, and they've also expanded to reach vulnerable populations, such as a Spanish language as well as Asian quit lines that target specific subpopulations to better broach this issue. But it's also important to note that a lot of smokers are not accessing quit lines, so we have an access issue, and that's only about 6% of smokers, and that's a high estimate, are actually calling the quit lines, even though that we know they can work. But again, the reach factor is not yet there in terms of quit lines and getting to the populations who need it. And I won't touch on this much, but we've already heard about mass media campaigns, and particularly graphic media campaigns have been shown to be most effective. As many of you might be aware, CDC had tips from former smokers, which started in 2012, and Legacy also has the Truth campaign, and FDA most recently released the Real Cost campaign. So we're kind of in a golden age of hard-hitting mass media campaigns, and it's kind of historic that we have not had this previously. We know these interventions work, and particularly with CDC's TIPS campaign, we saw in excess of 200,000 people who quit as a result of the 2012 campaign. And I will just end with my contact information. I have the misfortune of having the middle initial that makes my CDC email baking@cdc.gov. I get a lot of interesting emails asking about raw cookie dough and what the implications would be for eating that. But I'm happy to address any questions related to tobacco or triage it to anyone if you need assistance with a tobacco-related matter. And with that, I am set.